Omar, I will send the link on the group chat.
Hello, everyone, and welcome to the Oral Diagnosis and Radiology webinar series. My name is Omar, and I am the webinar director at the SCORE committee. It's a pleasure to have you with us today as we begin the new series. Before we get started, I would like to briefly highlight the International Association of Dental Students, IADS, which is a global network that brings together dental students from all around the world to support learning, collaboration, and professional growth. This webinar series is conducted under the SCORE Office of IADS, which focuses on research, education, and international engagement, providing students with valuable opportunities to learn from experts and expand their knowledge. We are excited to explore this specialty together, as oral diagnosis and radiology play a key role in accurate diagnosis and effective treatment planning in dental practice. We hope you will find the upcoming sessions both insightful and beneficial. It's a pleasure to have our speaker with us today, and we sincerely thank her for joining us and sharing their expertise. To introduce our speaker and guide us through the session, I would like now to hand over to my colleague, Emiliana.
Hi everyone, and welcome to this new webinar session dedicated to oral diagnosis and radiology. Today's session is titled The Most Common Imaging Findings in Oral Pathology, a Practical Guide. It focuses on a topic that is highly relevant in everyday clinical practice. Being able to correctly interpret imaging findings in the maxillofacial region is essential, not only to distinguish normal anatomical variation from pathology, but also to guide accurate diagnosis and proper patient management. It is therefore a great pleasure to introduce our speaker, Dr. Yamely Ruiz Vázquez, whose expertise perfectly matches today's topic. Dr. Ruiz Vázquez is a certified oral and maxillofacial pathologist. She earned a DDS degree from the Universidad Nacional Autónoma de México and completed her specialization and master degree in oral pathology and medicine at la Universidad Autónoma Metropolitana, where she received the Academic Merit Medal. She currently is a PhD candidate in basic medical, dental, and sciences at the Universidad Nacional Autónoma de México. And she also a faculty member in its Faculty of Dentistry, where she teaches oral pathology, oral medicine, and oral morphology. She is an active national international speaker, a thesis advisors, the author of publication and in indexed journal. She also serves as vice president of the Mexican Council of Oral Maxillofacial Pathology for the 2025-2028 term. And we are truly honored to have her with us today. Please join me in welcoming Dr. Yamely Ruiz Vázquez. I now leave the floor to her. Thank you, Doctor.
Thank you so much, Dr. Emiliana. And well, hello and good morning, everyone. Good morning from Mexico. I don't know where are you, but here in Mexico it's morning. And before we begin, I would like to thank the International Association of Dental Students for the invitation and for giving me the opportunity to share this topic with you today. So I'm going to share the screen and we start with this topic. And the title of the topic is The Most Common Imaging Findings in Oral Pathology, a Practical Guide. So I try to give you the keys, the clues for an easy diagnosis of when you are looking some radiographies or computerized tomographies. So that's the objective of this topic. And before we begin, I would like to state that the data and the information that present in this lecture have not been funded either wholly or impartial by any company with economic or political interest. And all the images that were obtained in accordance with the good clinical practice guidelines in compliance with the Mexican General Health Law. And for respect for the patients, don't distribute or share these images. So to be understand this topic, we begin by establishing the imaging terminology using in the two main dental imaging modalities that were radiography and computerized tomography or the CBCT. The basic radiographic descriptors are the terms radiolucent, radiopaque, and mixed. Radiolucent means that the image that we are seeing are black or are darkness than the other tissues adjacent. The term radiopaque means that the tissue or the lesion that we found, it's white or it's clear, more clear than the other tissues. And when we use the term mix, it's when we find some lesions or some entities that have this combination of these two images, radiolucent with radiopaque. In contrast, in computerized tomography or CBCT, the terms that we use in these images are hypodense, that is the same that radiolucent, but in tomography, the term is hypodense, and means that the tissue is actually same that radiolucent, it's black or darkness than the other tissues. The second term is if hyperdense. Hyperdense means that it's white or clear or more clear than the other tissues. And the term isodense means that it's the same, has the same density of the adjacent tissues. In addition to the above, there are some key points for the description and the occurrence diagnosis when we are interpreting some of images or some of these studies. The first key imaging feature are the borders. Borders are very important to describe, and we have two basic terms for describe the borders. The first is well-defined border. Well-defined border is when we can see the clear difference between the lesion and the other tissues. I put this example with this circle. You can see with only your view when this circle finish, when this circle begin. So that's the meaning of well-defined border. In contrast to ill-defined border. An ill-defined border means that you cannot see with clearly is the beginning or the end of the tissue or the lesion. In addition to these two types of borders, we have another two types of borders that not are always present in all the tissues and are not always present, and we have not always to describe in all the lesions. The first is sclerotic. The term sclerotic only applies by lesions or for lesions that has a radiolucent or hypodense density, but the border is well defined. But in addition, this border is hyperdense or radiopaque. That's the meaning of sclerotic border. But another word is radiolucent halo. Radiolucent halo means or applies only for radiopaque lesions. In these radiopaque lesions, when they are surrounded by this radiolucent border, that's the meaning of radiolucent halo. And as I mentioned it earlier, that's not applied for all the lesions, just only in particular. The second key imaging finding are the effects on the surrounding structures. The effects on these surrounding structures are four key points. The first one is the cortical expansion. For this, it's important that we have to know the cortical border in the basal mandible or in vestibular or lingual or palatine. It will depend of the cut or the view that the image we are observed. But cortical expansion means that the size of that bone is bigger than the normal size. For example, in this panoramic radiography, we can observe that the jaw have an expansion of this cortical. The border is wide than the normal size in the jaw. The second point is the cortical perforation. Not all the lesions that have cortical expansion could have cortical perforation. They could be separated, but sometimes the two are in the same lesion. So the cortical perforation means like that this image, when you are seeing the images, the border, lingual, vestibular, palatine, or basal in the case of the jaw, you can see the solution of the continuity. So this is the cortical perforation, the loss of this part of bone. The third one is the teeth displacement. Teeth displacement means that the lesions are growing, and sometimes when it's too much, it's bigger, the lesion can move this tooth to another position. This is very important because sometimes we can see this in some aggressive lesions. And the other one is root resorption. Root resorption means that the root or the dental tissue is reabsorbed by the lesion. This is another very important characteristic because when we look for root resorption, sometimes means that the lesion could be aggressive or maybe malignant. So this is the characteristics of the effects on the surrounding structures. And another key imaging feature that is a clue is the relationship with the lesion to the teeth. It's very important to describe the specific localization as precisely as possible because that gives us very important information, and with this information we can reduce the diagnosis, the differential diagnosis that we keep in mind. So the relationship to the teeth, for example, if the lesion is periapical, if I see for a periapical lesion, maybe I will reduce into maybe possible first diagnosis. If the lesion has a pericoronal relationship, like this image, that, for example, is very common in the dentigerous cyst, or if the lesion has an interradicular position or relationship with the teeth, or if the lesion has not tooth association. That is very important because, as I said before, sometimes that helps us for think in a specific or a differential diagnosis. And very important to keep in mind, we have here the characteristics that make us a difference between lesions that are benign and lesions that are malignant. Benign lesions has slow growing, in contrast to malignant lesions. Malignant lesions has a rapid growth. The second point is the well-defined borders. It's very common that the benign lesions has well-defined borders, in contrast to malignant lesions that has these ill-defined borders. The third important point is the symptomatology. Most part of the time, at the beginning, benign and malignant lesions are asymptomatic. However, malignant lesions with the pass of the time could be present or may present some symptoms like paresthesia or pain in advanced stage. And the other point is that benign lesions, most part of the time, has no destruction of the adjacent structures. In contrast with malignant lesions, that the destruction of the adjacent tissue is a very common finding. But important to remember, this is points are in general because this is biology, it's not exactly science. So some benign lesions may exhibit aggressive behavior and present one of two features typically associated with malignancy. That is a very important characteristic. So as mentioned earlier, Lesions may be radiolucent lesions or hyperdense maybe could have a radiopaque or hyperdense, or could be mixed. And based on this classification, we will review the most common entities in the daily dental practice, starting with the radiolucent or hypodense lesions. In this group of radiolucent or hypodense lesions, we have three groups. The first one are well-defined unilocular radiolucent or hypodense lesions. In this group, we have some entities like radicular cyst or radicular granuloma, dentigerous cyst, the Staphney defect, and an aggressive initial lesion. The second group are multilocular radiolucent or hypodense lesions. In this group, we have some entities like ameloblastoma, odontogenic keratocyst, odontogenic myxoma, and the giant cell central granuloma. And the third group are ill-defined radiolucent hypodense lesions. In this group, we have some entities like osteomyelitis and malignant lesions. A key point in this group, if it is the lesion that you are seeing or the image you are seeing in your patient is multilocular, maybe you could think that this entity is aggressive until the proven otherwise. And however, in contrast, the well-defined unilocular most part of the time could have a very good behavior or are benign lesions. But the definitive diagnosis is only established by biopsy. That is another point that is very, very important to keep in mind. In this group, the well-defined unilocular, we start with these two, radiolucent cyst and radicular granuloma. So in this group, or in this point, I have a question. Is there a difference in image between a periapical cyst and periapical granuloma? Sometimes, and many years ago, people think that, yeah, we can find some imaging difference between cyst or periapical granuloma. However, the answer at this moment is not. There are many scientific literature about, but this scientific literature has attempted to determine whether the image difference exists between these two lesions. If you share, you can find maybe some papers that say, yeah, there exists a difference. However, the size of sample, or they have some problems for the structure of the paper. But today, no studies support this. No studies support that exists a difference between cyst, the periapical cyst or periapical granuloma in image. The only difference is by the histopathological study. It's only by biopsy. So here, for example, we can see that in these two images, one is a computerized tomography, the other one is part of the radiography, a panoramical radiography. In the two images, we can observe the relationship of the radiolucent or hypodense entity surrounding the periapical part of the teeth, here and here, for example. And the size was one of the points that sometimes many people say, oh yeah, if the lesion is big, you can think maybe this is a cyst, a periapical cyst. No, that is false. The size of the lesion doesn't tell us if the lesion is a periapical cyst or periapical granuloma. In our practice, we can observe that sometimes the periapical granulomas could have a very big size, like more than 2 centimeters. So the size doesn't give us this information. And the other point that sometimes the people say, Oh yeah, the difference between granuloma or periapical cyst and imaging is the cortical border. No, this is a total lie. Cortical border don't give us the information about it. Cortical border only tell us that the lesion maybe has many years or more time than another lesion that has not a cortical border. So this is very important to remember. So in these two cases, one is the periapical cyst, that was this one, and the bigger that you see in the tomography is where the periapical granuloma. But the only way to see where who is who is only by biopsy. This is very important point to remember. So in the periapical cysts and periapical granulomas, we have key points for these lesions. The first one is if the tissue that you see or the image you see in your radiography or your tomography is unilocular, radiolucent, or hypodense lesion associated with the apex of the teeth, you can think that maybe this is an inflammatory condition like radicular cyst or periapical granuloma. However, as I said before, size is not determinant. Lesions may be larger than 2 centimeters, so even periapical cysts and also radicular cysts. Borders may or may not be corticated, as I said before. That does make us a difference between periapical cyst or periapical granuloma. However, a very, very important point is the vitality of the pulp. The pulp vitality test is an essential finding and an essential practice that we should do in all the patients that we are thinking in these two lesions. So make the test of the pulp vitality with cold, with heat, or percussion, give us a very important information. Because if the tooth does not respond appropriately to the vitality test, the lesion is likely inflammatory. So that means that the lesion could be a periapical cyst or periapical granuloma. In this case, the endodontic treatment or extraction, it could depend about the teeth, the patient, and another characteristic, but this endodontic treatment or extraction could be required. And the lesion should be removed and submit for the histopathological evaluation. Because as I said before, these entities has no difference in image. I can only see the difference by the histopathological evaluation. However, if the tooth is vital, surgical removal of the lesion were made only. So the tooth, if the tooth is vital, the tooth doesn't need an endodontic treatment or an extraction. So that the importance of this clinical interpretation about the full vitality test. The second entity in this group of the well-defined unilocular lesions are dentigerous cysts. This dentigerous cyst is a radiolucent or hypodense entity that the localization is very important because they will always be associated with the crown of an unerupted tooth, commonly molar or another tooth like an ends. This entity arises from the cemento enamel junction. That is a very, very important finding for think in this diagnosis of the dentigerous cyst. This is a benign condition. The size of this entity sometimes it's 1 or 2 centimeters. However, we can observe some lesions that are bigger than this size, could have 5 centimeters or even 10 or more centimeters. So at the beginning it's a small lesion, but if you doesn't remove this entity, this could be growing, has a benign behavior, but with the pass of the time or with the pass of the years, could have another characteristics like the cortical expansion, for example. The third entity of this group of well-defined unilocular entities are the Staffney defect. Staffney defect is not a pathology like that. This is more considered than anatomic variation. Is a finding that is located in the posterior mandible, jaw, body of the mandible, and below to the mandibular canal. This is an asymptomatic finding. Clinically, it has not some characteristics that makes us to think that there is something in this bone. This is only a radiographic or tomographic finding. And no growing, and only is an incidental and an innocuous finding. So when we look for a Staffney defect, we the first of the key point of here is the localization. Most part of the time, the 80% of the cases are below of this mandibular canal, as I see in this part of tomography. And in this 3D reconstruction, we can observe this loss of bone, but it's we all the time, it's important to remember that 3D reconstruction only gives us some characteristics, but we always have to make the correlationship with the complete tomography. And the last entity of this group are well-defined unilocular entities are an aggressive initial lesion. It's important to remember that the big, the huge, and the aggressive entities, like we know, like ameloblastomas, keratocysts, that we are most part of the time see big or huge. At the beginning were not of that size. At the beginning, that lesions were small lesions. And sometimes these entities were confused with another lesions, as I see before, with how like radicular cysts, radicular granulomas, or even dentigerous cysts, because these entities start small, no starts big or huge. So in this case, for example, in these two images that you see in this slide, this one were an ameloblastoma, but however, if you see the image, maybe you first think in a diagnosis like radicular cyst or radicular granuloma. And that's the importance for make the pulp vitality test. In these cases, the tooth is vital, so the tooth could stay here there, but the lesion, yes, has to be removed. In this case, another one where odontogenic keratocyst, if you see the entity is very small, has 1 centimeter of diameter, and are between the roots of these tooth. So, as the same the last image, you can think that maybe it's an inflammatory entity like radicular cyst or radicular granuloma. However, the teeth are vital. So every large and aggressive lesion begin small. That is very important to remember. And that's the importance for the histopathological evaluation. Because if you take this and take to trash, well, you have another huge entity because you doesn't know who is this entity. So the histopathological evaluation is essential for these entities. The second group are radiolucent hypodense entities that has a multilocular pattern. In this group, we have entities like ameloblastoma, the odontogenic keratocyst, and the odontogenic myxoma, and giant cell central granuloma. These entities, most part of the time, has some patterns. These patterns are the subbubble pattern of the multilocular, radiolucent, or hypodense entities. Sometimes means that the lesion, the entity could have or may have an ameloblastoma. We have the pattern of honeycomb. The honeycomb pattern, it's more likely to think is an odontogenic keratocyst. And that means that the subbubble, that the locus are big, and the honeycomb are medium locus. In contrast with the tennis racket, the tennis racket pattern, it's more consistent with odontogenic myxoma, and that means that the locus are very, very small locus. However, as I said before, this is biology. Sometimes odontogenic keratocysts could have the subbubbled or the tennis racket pattern, and sometimes ameloblastoma could have the honeycomb or the tennis racket pattern. But most part of the time, that's how is each one. The aggressive futures plus that the pattern, these entities has another aggressive futures like cortical expansion, cortical perforation, tooth displacement, and the root resorption. And the other one, the giant cell central granuloma, this entity at the beginning could have a unilocular aspect, but when this has a growing, could have a multilocular pattern. And the pattern that the giant cell central granuloma presents are multilocular with big, medium, or small size of the locus, size of the locus. So could have the subbubble, honeycomb, or the tennis racket pattern. So this is giant cell central granuloma. Sometimes like the other entities, this lesion has an also aggressive futures like cortical expansion, tooth displacement, tooth resorption, and even some symptoms like paresthesia. So this is very important to remember in these entities that are considered aggressive. And the last group of these radiolucent or hypodense entities are well-defined lesions. These lesions has well-defined borders. First one is osteomyelitis. Osteomyelitis is appears as ill-defined areas with these irregular borders and has a mood-eating appearance that it's very important, finding to think that maybe this image that you are seeing is an osteomyelitis. And think in malignancy. If you see ill-defined borders plus aggressive futures like cortical expansion, perforation, tooth displacement, root resorption, even some symptoms like pain or paresthesia, you maybe could think that the entity you are seeing it's a malignant entity, like in this case. This case, you can see two different tomographies, and we can observe these findings with cortical perforation, with ill-defined borders, with tooth displacement, with the invasion with another tissues, that it's very findings that are common in malignancy. So this is the group of radiolucent or hypodense entities. The third group are radiopaque or hyperdense lesions. In this group, we have two other groups. The first one is incidental findings. Incidental findings are innocuous or harmless entities. In this group have some pathologies like condensing osteitis, idiopathic osteosclerosis, and cementoosseous dysplasia. And the other group are, the other group are pathology when in that biopsy is required for the diagnosis. In this group, we have entities like odontoma, osteoma, ossifying fibroma, cementoblastoma, and the fibrous dysplasia. Important to remember of a key point or a clue in this radiopaque or hyperdense entity is harmless radiopaque lesions require only annual radiography, like follow-up, like condensing osteitis, idiopathic osteosclerosis, or the cementoosseous dysplasia. However, in the condensing osteitis, we have to remove the inflammatory source, because if we do know that, the condensing osteitis will continue. So the first of this group is the condensing osteitis and the idiopathic osteosclerosis. The condensing osteitis and idiopathic osteosclerosis are radiopaque or hyperdense entity, as you can see in these images. This is a condensing osteitis, and this one is a idiopathic osteosclerosis. The main difference between these two entities are that the condensing osteitis has an inflammatory origin, in contrast with idiopathic osteosclerosis, where the cause is not identifiable. So the other difference between these two entities are that condensing osteitis, so most part of the time, are round or oval, in contrast with idiopathic osteosclerosis that has a not regular pattern or not regular form, not you can compare with a geometric figure. So this is the other important difference between these two entities. So both are asymptomatic and do not cause cortical expansion. So clinically, you can also suspect that the patient has one of these entities. Our imaging findings are only if you maybe take a radiography or tomography for another reasons, like third molar striations, like orthodontics. You see this and say, oh, which is this? I see. So yeah, that are incidental findings. That's the reason that are in this group, incidental findings or innocuous entities. And the theory of this group is the cementoosseous dysplasia. Cementoosseous dysplasia is a benign, well-defined radiolucent mixed or radiopaque. That means that this entity is not always with the same density. At the beginning, when this appears, is radiolucent. With the pass of the time, are mixed, and at the end are radiopaque. So this entity could have the third images in radiography or in tomography. The other important thing for this is that could has a single, can find one lesion in the patient, or or could have a multiple presentation. As I see in this panoramic radiography, you can observe the 1, 2, 3, 4, 5, 6 radiopaques entities. Here there are another 2, 7, 8, and here we have a mixed. So that's the definition or the behavior of this entity. At the beginning is radiolucent, then become mixed, and then become radiopaque. It is an asymptomatic pathology that does not cause expansion cortical expansion, or there are associated, if you see teeth, the teeth associated with these lesions are vital teeth. That's another very important key point or clue for the diagnosis. And this entity doesn't grow up, only change in density with the pass of the time. So this only treatment is the follow-up by radiography or followed up by tomography 1 year, each year. The second group in this radiopaque or hyperdense entity, we have pathology that requires biopsy for give us a diagnosis. The first of this group are odontomas. We have two types of odontomas, compound and complex odontomas. Compound odontomas show like this image that I'm here, this one, this is a compound odontoma. And the difference between compound and complex is the appearance. Both are a radiopaque. However, the compound odontoma shows the silhouette or multiple tooth-like structures. You can see maybe remember a very, very small tooth. So, but it's tooth-like structures. That's the finding or the important finding in compound odontoma. Whereas the complex odontoma appears as a single radiopaque neoplasm. And however, both of them should be removed and analyzed by histopathological by histological study, because there are another entities that could have this appearance, but the most important and the most common are the odontomas. So this is the first one. The second are osteomas. Osteomas are completely radiopaque entities that has a well-defined border. This is our benign entity that are typically located in the mandibular body and the condyle. So they are asymptomatic and has a slow growing. So this is the finding of our osteoma. So if you see a completely radiopaque entity, maybe you can think in this diagnosis. The third one is the ossifying fibroma. Ossifying fibroma is a neoplasm. This is a benignant neoplasm that may cause cortical expansion, may cause cortical perforation even. It has an important growth. These lesions became very, very, very big, became huge. The biggest that I see has a maybe 18 or 20 centimeters. So this entity, yeah, could grow very, very big. So this is very important to remember. It's benign, yeah, but has a very important growth. So this causes cortical expansion, cortical perforation, maybe tooth displacement, or even root resorption. And similar in the cementoosseous dysplasia, the ossifying fibroma could may appear like at the beginning radiolucent area or hypodense area, then with the pass of the time became mixed, and at the end became radiopaque, as I see in this panoramic radiography. The other important radiopaque or hyperdense entity is the cementoblastoma. Cementoblastoma is an odontogenic tumor. It's a benign lesion, but sometimes cementoblastoma may exhibit an aggressive behavior. That's the importance of knowing this entity or knows this pathology. So this cementoblastoma is characterized by a radiopaque, as I see in these images, a radiopaque area from an intimate associated with the root. This is a very important and the key for the diagnosis or thing that the entity you're seeing is a cementoblastoma, the intimate association with the root of the tooth. So with sometimes obliteration of the root outline. And the entity, as I see, is surrounded by this radiolucent halo. This is another important finding in the cementoblastomas. Cementoblastomas are asymptomatic. However, one third of the cases are associated with symptomatology like pain. So it's a rare odontogenic tumor, but the image is unique. So that's the reason for it's important to know. And the last one is the fibrous dysplasia. Fibrous dysplasia is a benign fibroosseous lesion that has a radiopaque characteristic or hyperdense characteristic, but some key point in this one is the appearance. This lesion has a pattern, and the pattern is described like a ground glass. Ground glass appearance is the very important finding for think that the entity you are seeing in your tomography or in your radiography is a fibrous dysplasia. Also, this entity could have aggressive behavior because they cause facial asymmetry, cause huge dimensions, but some important difference, for example, between ossifying fibroma is that the fibrous dysplasia has not cortical perforation. This is a very important key point or a clue for think in this diagnosis. But the ground glass appearance is the pathognomonic characteristic of this fibrous dysplasia. And the last group are the mixed lesions. In these mixed lesions, we have the incidental findings, innocuous, as I say before, the cementoosseous dysplasia that could have a radiolucent or mixed or radiopaque appearance. And the other group are pathology that are the biopsy is required for the diagnosis. And we have entities like ossifying fibroma that I see before, but we have another new entities like calcifying odontogenic cyst, like calcifying epithelial odontogenic tumor, the adenomatoid odontogenic tumor, and the osteosarcoma. These lesions are initially radiolucent or hypodense, become mixed over the time, and may eventually appear completely radiopaque or hyperdense. That's the importance of the mixed lesions. Mixed lesions does not appear mixed at the beginning, are hyperdense or radiolucent at the beginning, then they become mixed over the time, and at the end or with the pass of the years, may eventually appear completely radiopaque. That is very important to know for these mixed entities. So the first one I see before is the cementoosseous dysplasia. We see that this is a benign, well-defined condition, is a radiographic finding, even if it's multiple and have many lesions in the maxilla or in the jaw. The patient is asymptomatic with no cortical expansion, with no asymmetry. So the patient is like another normal patient. But when you see the radiography or the tomography, for another reason, sometimes are planifications for prosthetic, for orthodontic, or for surgeries. So you look for this one, and it's very important because sometimes the multiple appearance make us think that this is another type of entity. But remember, this is a benign condition with these characteristics. The other group of these mixed lesions are pathology when biopsy is required for the diagnosis. In this group, we have, again, the ossifying fibroma. Ossifying fibroma, I see before in the radiopaque entities, is a benign neoplasm with cortical expansion, cortical perforation, tooth displacement, root resorption, radiolucent, mixed, or radiopaque appearance. In this case, we have, in contrast, like the first one, see where when we see that the entity were completely radiopaque, here we can observe that the entity is mixed. We have some hypodense appearance with the presence of hyperdense points or hyperdense areas. well-defined borders. However, we can observe here the perforation and the expansion of this cortical bone. The other entity here are calcifying odontogenic cysts. Calcifying odontogenic cysts is another very important entity. This is a benign entity, is an odontogenic cyst, but as the name says, calcifying. It, with the pass of the time, become mixed over the time, and the lesion initially is radiolucent or hypodense. However, in contrast to ossifying fibroma, this calcifying odontogenic cyst has well-defined borders and has not aggressive behavior. This is a very benign entity that sometimes could cause displacement of the tooth, but no, it is associated with root resorption or bone perforation, has a very benignant behavior. The third one are calcifying epithelial odontogenic tumor. In contrast with calcifying odontogenic cyst, calcifying epithelial odontogenic tumor, also known like a Pinberg tumor, has a aggressive behavior. This is a very important difference between the last one and this entity. The localization of this calcifying epithelial odontogenic tumor, most part of the time, are the posterior area of the mandible in the body or part of the ascending area of this jaw, and has well-defined borders, but in the density is a mixed density. We can observe some radiolucent areas in combination with a radiopaque areas. If we are seeing a tomography, we have hypodense or hypodense areas in combination with hyperdense areas. This entity, as I said, could have aggressive behavior, so may cause root resorption, cortical expansion, and even cortical perforation. And the third of these odontogenic tumors that are mixed or has a mixed pattern are the adenomatoid odontogenic tumor. Adenomatoid odontogenic tumor is another benign tumor, the odontogenic origin, and the odd is initially radiolucent or hypodense, and with the pass of the time, it became mixed. In contrast to the Pinberg tumor, this is a mix with salt and pepper mix defined or described pattern. The pattern that are associated with adenomatoid odontogenic tumor are the salt and pepper. That means there is a combination with this hypodense or radiolucent, if you are seeing a radiography, hypodense or hysodense with these points that has an hyperdensity. That's the salt and pepper pattern. This entity has a well-defined border, and the localization is most part of the time in the maxilla, in the anterior part, and often associated with uneropter tooths, and sometimes the tooth that are associated are the canine. And the last one of the mixed lesions are osteosarcomas. Osteosarcomas are ill-defined entities that are malignant. The osteosarcoma is a malignant neoplasm of the bone, and for this reason has a malignant behavior. Has a rapid growth, ill border defines, has a cortical perforation, root resorption, cortical expansion, and sometimes some symptoms like the numb change when it's located in the jaw, or paresthesia, or pain even in sometimes. In some views of the tomography, so maybe in the axial cut of the tomography or in some occlusal radiographies, sometimes it's possible to appreciate a pattern in the osteosarcoma. The pattern that are related with the osteosarcoma is described as a sunburst. This is sunburst pattern is classic and pathognomonic of osteosarcoma, but it's not seen always. You can see only this sunburst pattern in axial views or occlusal radiographies. So this is or lesions. So for end this topic, in conclusions, was as I see before, how we can approach this case, or how can we approach a case when we look for a radiography or look for a tomography and we find or look for something that is strange for us. First, you can remember localization. Localization is a very important clue. Second one, density. Density if it's radiopaque, mixed, or radiolucent. This is very, very important because as I see, you can think with the density in some particular entities. The borders, if the border is ill-defined or well-defined, tell us about the aggressive or behavior or the benign behavior of the entity. And the relationship with the teeth. Remember, this is another very important clue. The relationship with the teeth give us information about particular diagnosis. And do not jump to a diagnosis. It's very important, build step by step. This is because sometimes it's hard to remember the names of the exactly pathology, but if you know the important characteristics, it's very easy, and it's most easy than if you have no information. So do not diagnose by the name, diagnose by the pattern. This is a recommendation that I give us. And if we have ill-defined borders, maybe suggest an aggressiveness. And if we have tooth relationship, is often the key clue for think in a specific diagnosis. And remember, some images like radiography or only the 3D reconstruction are, we have poor information about the lesion. Sometimes we need the CT imaging complete, and these findings can significantly change the diagnosis. So remember, image doesn't not give you the diagnosis, but image tell us what we can think. And the definitive diagnosis is only established by biopsy. And thanks again for the invitation. Thank you very much, Dr. Emiliana, and thank you very much for the International Association of Dental Students for giving the opportunity for stay with you today. Thank you very much.
Oh, thank you so much, doctor. And we have some questions. So the first question is, what is the most challenging oral lesion to diagnose radiographically and why?
Okay, maybe the malignant entities, because sometimes the malignant behavior are make us think in another or a huge differential diagnosis. So I talk about osteosarcoma, but we have another malignancies like carcinomas, lymphomas, another type of sarcomas. So this is a very, very important, and it's a challenge. So in another view, also is a challenge because benign aggressive lesions has sometimes characteristics of malignancy. And even you at the beginning think, okay, this is benign aggressive or this is malignant. And the challenge is dealt to the patient. You know, it's like this.
Okay, so why an impacted tooth could give origin to cysts or tumors?
Yeah, in impacted tooth, the most entity or the most lesion associated is dentigerous cyst. However, in impacted tooth, we can develop another important tumors or cysts like odontogenic keratocysts or like ameloblastomas or even odontogenic myxomas. That's the important, that if you see an impacted tooth, you have to remove it.
Okay. If a teeth presents cementosseous dysplasia, how we should manage extraction if it's indicated for these cases?
No, there is no treatment indicated for this. If you think this is a cementosseous dysplasia, the only indicated thing that you do is make a radiography or a tomography annually.
Okay. So our last question is, in your clinical experience, what are the most simple lesions to be radiographically mistaken?
Okay, in my experience, are the initially entities like ameloblastomas at the beginning, odontogenic keratosis, that sometimes dentistry thinks that they are inflammatory pathology, like periapical cysts or periapical granulomas, and take to the trash, and just before we have a bigger or a huge entity that were a meloblastoma or a myxoma or odontogenic keratosis at the beginning.
Okay. Thank you so much, Dr. Yamely. And you are such an inspiration. And I want to be a oral pathologist myself. So women like you made me dream big. And so on the behalf of the organizing team, we will sincerely thank you for your valuable contribution and for sharing your expertise with us today. It's truly been an honor to host you during our webinar session. I would also like to thank all the participants for attending our our webinar with interest. And before you leave, please remember to scan the QR code for the attendance. And finally, we will be delighted to welcome you to our next webinar of this series, which will take place on April the 2nd, featuring the Professor Reinilde Jacobs. Thank you once again for joining us, and we hope to see you in our upcoming events. Have a wonderful day or evening. So thank you, Dr. Yamely.
Thank you so much again, and see you soon. Thank
See
you.
you.